انت ممكن حضرتك تفضل فاتح على البرزنتيشن يعني.
طيب اوكي ماشي.
هو عبد الله مش موجود ولا ايه؟ انت ممكن حضرتك تفضل فاتح على البرزنتيشن يعني. We are live now.
اوكي هنبدا قبل ميعادنا ولا هنبدا في ميعادنا؟
لا لا هنبتدي في ميعادنا، بس انا بس يعني بطمن ان السيتنج تمام.
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
ايه الاخبار يا شباب؟
ازيك يا عبد الله؟
الحمد لله. ازيك يا باشا؟
انا هخليك كو هوست دلوقتي يا باشا.
تمام.
بسم الله كو. تمام. تقدر بقى تشير اللينك دلوقتي؟
انت عامل لايف اون يوتيوب؟
يس.
طب ليه احنا كده اتفضحنا كده؟
ليه لا ما اتفضحناش؟
بنتكلم بالعربي.
عادي عادي.
I'm going to share now.
اوكي.
هل انا ممكن اخد البث ده منك يا دكتور احمد؟
بيتسجل يا دكتور دسوقي، وبيبقى ظاهر عندي على القناه كل الليكتشرز بتاعت امبارح اوريدي اتسجلت، والنهارده هتتسجل برضو بامر الله.
لا انا اقصد هل ممكن اخد من عندك البث ده احطه لايف عندي على اليوتيوب؟
لو تعرف تعملها اوكي طبعا. انا ما اعرفش بتعمل ازاي.
لا ده خالص.
You are ready dear دكتور عبد الله؟
Not yet.
اوكي. Notify me, please, when you are ready.
Okay. Just a minute.
Okay, take your time. دكتور محمد حمدي. Dr. Muhammad Hamdi, can you hear me?
Okay, we are now on Facebook also, okay?
Okay. It will be recorded automatically.
Dr. Ahmed?
Dr. Muhammad, don't forget to record the lecture.
It will be recorded automatically.
Okay.
No problem.
Great.
The live stream is okay?
Okay, very good.
Okay. Can you make me a co-host?
Yes. You are a co-host and Dr. Abdel al-Maghrabi as well.
Okay, we are ready now. You can introduce the speakers and the program of today.
Okay.
Dr. Ahmed, please make me a co-host again.
Okay, no problem.
Okay.
Now you are a co-host?
Yeah, thank you.
Okay, you are welcome.
Thank you.
Good evening, my dear friends from all over the world. Today we will continue our online webinar about COVID-19. Today we will have three lectures, and we will start with a very important lecture about stepwise approach for management of COVID-19 patients, and it will be presented by Dr. Desouky Abdel Aati, consultant chest physician from Germany. This lecture is very important as we know, Germany is one of the most successful countries in the world as regard management of COVID-19. This is shown as the lowest mortality of COVID-19 patients among all countries. So we are so excited to know what is the protocol of management in Germany. I think we have some time before we start at 7 p.m. exactly. The second lecture today will be presented by Dr. Shady Hamoda, and he will talk about CPR and aerosol generating procedure. This is also very important lecture, and we will enjoy his excellent presentation. The third lecture will be given by Dr. Ahmed Farid, and he will talk about precautions during cardiac imaging. We will continue our online webinar tomorrow at the same time with two important lectures. The first one by Dr. Alexander Nosikov from Bulgaria, and he will talk about venous thromboembolism in the era of COVID-19. And Dr. Hatem Sulaiman will talk about ventilation and lung ultrasound. The feedback about yesterday was really amazing. We got almost 1,000 views on YouTube, and I expect more views for the upcoming lecture today and tomorrow, inshallah. Each lecture will last for about 20 minutes, and it will be followed by discussion for 10 minutes. After each lecture, Dr. Abdel al-Maghrabi will collect the question from YouTube and from the Facebook, and we will answer it at the end of the lecture. We will start after about 2 minutes. Okay, I think we should start now. Dear Dr. Desouky, are you ready?
Yes, I'm ready.
Thank you. Let's start, please.
Thank you, Dr. Ahmed. Dear moderators and the group who organized this interesting lectures and this very big and good organized and well-organized webinar, I'm very thankful to be invited to that. My name is Desouky Aati, or Desouky Aati in the Egyptian accent. And I'm a consultant chest physician. I'm working in the Helios University Hospital in Wuppertal, Germany, and I'd like to share today an experience-oriented stepwise approach of management of COVID-19 infection with a special interest in the diagnosis process and in the therapy process, where I will just give some aspects I will highlight some aspects in the therapy process. First of all, I don't have any conflict of interest, and this presentation is just for educational and informational purposes. My objectives of this talk is to build a clear pathway for diagnosis and to share my experience and to discuss some conflict situations. And I believe that in the time of pandemics, we need to use all our resources and personnel. So I would like to, and I'm telling my colleagues, my trainees, and our lead in the university that we must ensure a simple way of diagnosis for every physician. Also, those who are not with internist background to be ready if the pandemic goes in its dangerous position. My agenda of the talk is based about the therapy, diagnosis and therapy. So I will begin just in a classic beginning about the pathophysiology, and we would like to highlight that the coronavirus and in its second edition or third edition is not that bad in its pathology, but it is very bad in its distribution and in its transmission. So the pathophysiology is like every virus, it is transmitted by droplet infection or aerosol, and it goes in the upper and lower respiratory tract cells, invades it and goes through receptors and controls the cell and begins to replicate, and then begins with its pathogenesis. The pathogenesis is pneumonia in its moderate, severe, or critical form, lobar pneumonia or bronchopneumonia. We know now virus that the antigen presentation and cellular immunity both provide a cytokine storm, and this cytokine storm in different grades will make a very immune damage to the lung when it is really in its severe case. And this immune damage through this cytokine storm, it is now, at least with the available information, the cause of pathogenesis in the COVID-19 infection. We have a very good work from Gattinoni et al. Gattinoni had this work with the University of Göttingen in Lower Saxony, Germany, and he could perform a differentiation between two types of COVID-19 pneumonia: the type L, which you can have in mind as low mortality and low severity, and the type H, which you can keep in mind as a high mortality and high severity. The type L had a low elastance, a low ventilation to perfusion ratio, and a low lung width and a low lung recruitability. The type H, on the other hand, is against that all. It has high elastance, high right to shift shunt, high lung weight, and high lung recruitability. And as we said, it is a high mortality and a high and a severe phase of COVID-19 pneumonia. And the diagnosis is based of a triad. This triad is tells us that a confirmed case of COVID-19 infection has three limbs: the epidemiological history, the clinical manifestation, and then an evidence of the disease through lung imaging or the PCR from SARS-CoV-2. And this triad, I find it as the simplest way for every physician to ask himself, does this patient fulfill the criteria which is required to say he is a COVID-19 patient or not? And when we, in the worldwide, use this triad, I think we will have a very good approach to the COVID-19 infection. So, in the epidemiology, you must be a bit curious about the patient and ask him some questions which in the normal conditions is not the first to ask. I can remember one of my directors who asked me how did I get the history of a patient about the contact with asbestos. And I've told him I have asked the patient, and he said, no, I didn't have any contact with asbestos. And he asked me if I asked the patient what does he work, about some details in his work. And at the end of the day, we have diagnosed a very documented contact with asbestos because I didn't ask the right question. So if you ask the patients, do you have any sick patient in the family? Did you have a contact with him? And he can say, no, I didn't have, but you can, with some leading questions, you can know more about the patient. You must put that in your mind when you are asking about the epidemiology of the COVID-19 infection. The Chinese have documented their experience, and they have given us a very good approach. We have in Germany a similar approach, but I like the Chinese approach. It is more universal, and you can summarize it. If the patient meets one epidemiological history, that this means he had a contact in an area with a lot of infections or with infected patients, and two clinical manifestations, let's say fever and dyspnea, then you are suspecting the COVID-19 infection. If the patient has no epidemiological history, but three clinical manifestations, fever, dyspnea, and some cough, then you are suspecting COVID-19 infection. If the patient has no epidemiological history, then you can say, but you cannot exclude it through imaging. Please consult your expert concerning the case. The clinical manifestation, we must not forget, it is at the end of the day another respiratory virus. So, clear to say, there are no specific clinical features that can reliably distinguish COVID-19 from the viral respiratory infections. It is another virus. Also, when it is high distributed and in a pandemic case, but it is a respiratory virus. You must profile your patient according to his risk factors. You must not forget, you are not treating only his infection, but you are facing the next challenges from his heart, from his diabetes, from his hypertension, chronic lung diseases, and from his from his age. Also, if the patient is very old, we know it is linked to a high mortality, but don't forget that a young male can land by you in the ICU in ARDS stage, and you must look after him. The most common clinical features at the onset of illness was fever, fatigue, dry cough, anorexia, and some non-specific myalgias, dyspnea, and sputum production. The most less common symptoms were, and I have seen it a lot of times, smell and taste disorders. And if you have a female patient which has a corona or a COVID-19 infection, she will tell you I cannot smell or taste very good. I have 4 patients, and the 4 female patients have told me they cannot taste or smell since 2 weeks. So the other GIT symptoms are non-specific, and also these skin manifestations are described and documented, but we don't have any documentation or association that is clearly associated to the COVID-19. It is very important to perform a stratification of your patients according to the severity of manifestations. This stratifications is one of the cornerstones in the management of COVID-19. You must know if it is a mild case, the patient has no pneumonia and he has mild symptoms, or moderate cases with pneumonia and some acceptable and tolerable respiratory symptoms, or the severe cases with pneumonia and hypoxia, and one of the criteria which are in the third item here, and the critical cases with a necessity to be managed in the ICU. And the critical cases can be differentiated and more differentiated according to the oxygenation index and the compliance of respiratory system. We can use the both of the aspects to differentiate the critical case in early, middle, and late stages. And the late stages have the worst prognosis in the COVID-19 infections. Take care. This stratification will decide for you where should your patient go. Back to home if he has just mild symptoms and he has not any necessity to be followed up, or ward admission if the patient has just a pneumonia and he does not have any hypoxia, or you need to admit your patient in the IMC, intermediate care unit, or the ICU. Has your patient pneumonia? Is your patient hypoxic? Are the very, I can say they are the most important questions which you ask yourself. Take care of his comorbidity and look at the whole context and don't look at the patient in a single way. The prognostic profile, you can get it through the labor parameters, CRP, procalcitonin, ferritin, D-dimer, and these acute phase parameter for the infections. You can get it, and according to the parameters, you can say if the prognosis of this patient will go okay, or it will be a very big challenge for us. But we must have a procalcitonin in the beginning to avoid the mistreatment without antibiotics, because a lot of those people are community-acquired pneumonia or nosocomial infection, and we don't know that. So we need it. We need always to have a procalcitonin, because without a procalcitonin, it is not advisable to give the patient an antibiotic. The PCR test is a very specific, but has a lower sensitivity of 65 to 95%. And this 95%, you cannot get it without a deep bronchoalveolar lavage. So it's still with high specificity, but a low sensitivity. But at the end of the day, it is the available one. And we cannot do a bronchoscopy for every patient to get his diagnosis. The radiological studies, the chest film, chest X-ray is insensitive in the early phase of the disease, but you can use it to follow up the cases after establishing the diagnosis. And this example here is pretty good, telling us that we can use the chest X-ray for the follow-up. The CT scan is our gold standard, and I find the specificity with 93 to 97 in some studies is very good. The ground glass, the crazy breathing, and the vascular dilatation and traction bronchiectasis and subpleural bends and architectural distortion in the late phases of the disease are very good. And even a surgeon who is not busy diagnosing the chest films and chest CT scan in a training from 1 week to 2 weeks, looking at these films, he can diagnose it very good. The initial CT pattern in COVID-19 with the ground glass, bilateral involvement, and the posterior distribution, the multilobular involvement is very good to see. Also the peripheral distribution and the CT changes over time have been in a lot of studies, especially in the Netherlands, well documented. The discussion points here is the following. A question, the PCR is negative, what should I do? You must look at the other aspects of your patient. If the patient fulfills the criteria of a suspected case, or he has therapeutic consequences to be admitted in the normal unit or in the IMC, then please do it and don't bother yourself with the PCR result. Should I perform a CT for every patient? No, absolutely not. You don't need to send every patient to the CT. Otherwise, you have some research studies or some research project, and you will make an agreement between you and the patient. But to perform a CT for every patient, I don't find it a good idea. And in the pandemic situation, when it is a horror, we cannot do that. The CT is indicated when you need it, and the need for this is the whole context of the patient. We can make a fight with the radiologist and say we need a CT if we find the indication for it, or we have an unclear situation. But if the patient is already with a chest X-ray diagnosis and we have a positive PCR, then what? Send the patient to his unit. The typical symptoms with the negative findings leads to treat your patient. The typical finding and no symptoms leads to follow up, and the bronchoscopy is a question of an aerosol generating condition, and we have a lot of precautions in the bronchoscopy. The case definition possibilities, according to Robert Koch Institute, this is our German Center for Disease Control, and it is somehow a local protocol about the case definition, but I find it very helpful. So I would like to introduce it. If the patient only clinically diagnosed, it is not applicable and not acceptable. Clinically and epidemiologically confirmed symptoms and history, but PCR is negative. This is a case of COVID-19. Clinically and lab confirmed case, this means symptoms and positive PCR. This is the ideal case. Lab confirmed without clinical relevance, this is a symptomatic case, and there are much of them. And lab confirmed infection with a known condition, this is the absent patient or the non-registered. Highlights of the therapy. And I have chosen this picture because we are, I think we are going in the process of therapy of COVID-19 infection with the same speed here. And I can begin with the most recent review for the drug therapy from Sanders et al., and it is published 13 April. Before a couple of days, no therapies have been shown effective to date. And in this review, all the studies and all the papers about the recent drug therapy for COVID-19 infection in the last time was included. We don't have any therapy for the COVID-19, but we have a plan, and I think you should not distract yourself with the picture of Mr. President Trump. We are, at the end of the day, internists, and our therapy strategy of COVID-19 patient is support your patient, support him, please support him, and anytime check if the virus is gone. This is our plan, and I think Bit by Bit is a very famous book for us in the English learning in Egypt, and I want to tell you my take-home message. Must your patient be admitted? Please classify him. Is he a mild, moderate, severe, or a critical case? And then perform your approach according to this classification. Can we diagnose a pneumonia for your patient? Please consider complications, and if you will discharge the patient, then make a very good and tight follow-up with him. that the patient needs to take antibiotics. Don't forget the bacterial pneumonia, and please take from your patient a procalcitonin control, because it is in 7 to 10 days anyway elevated and will not be useful for you. Please make a restrictive fluid strategy for your patient, because it interferes with the oxygenation of your patient, and optimize his nutrition, and monitor his vital signs, control it, and take care of his deterioration. And my golden aspects and my golden advice to you: be ready for escalation of the therapy of the patient, because it can deteriorate himself from a mild to moderate, from moderate to severe, and from severe to critical, and from critical from early stage to late stage. And do it yourself, because before he obligates you to do, and you don't want to find yourself in the situation, I must crush intubate this patient because he is severe hypoxic, and I must intubate him, and you don't have your facilities, and you are on 2 o'clock in the morning, and it is a difficult intubation, and the patient is hypoxic, bradycardic, and then CPR. So please be ready for your escalation. Do it yourself and plan it before he obligates you to do that, and ask yourself every time: is my patient hypoxic? Done. Oxygen therapy. I will not speak about the details of the oxygen therapy. I will tell you my experience and the experience of our leads. It is a matter of titration and adjustment. You measure the oxygen saturation of the patient and say he is 93, and you ask yourself to which profile belongs to this patient. Is he a lung patient, or he's a healthy lung, or a pregnant woman? And then you perform the titration: 1 liter, 2 liters, 3 liters, 4 liters, 6 liters, or high flow, or CPAP mask, or another form of oxygenation according to the control, and adjust this and escalate and de-escalate according to the titration. So you can read it here about the oxygen therapy. It is very detailed and with a lot of numbers, but it is a matter of titration and adjustment. Usage of glucocorticoid when necessary. Please do it if you seek stability for your patient in a shock situation. It is a strategy against shock, against multi-organ failure, but it is not, definitely, it is not a rule of the normal COVID patients. Otherwise, you have a COPD or asthma patient, or someone who must take the glucocorticoids for every other reason. And this is the application procedure. And Dr. Ahmed, I'm coming to the last slides of my lecture. The COVID-19 infected patients, whatever, hospitalized or ambulatory, are at high risk of thrombosis. Early and prolonged pharmacological thromboprophylaxis with low molecular weight heparin is highly recommended. This recommendation comes from a very good work which is published in the American Journal of Hematology. It is just before a couple of weeks, and I find it now in every protocol for the treatments. The specific drug therapy, I have told you in the first of the therapy capital, we don't have any specific drug. Don't be tricked. Don't be distracted with the everyday social media. We don't have it. We give our patient azithromycin for 3 days, 500 milligrams. The Americans give their patients the statins, 40 milligrams. We give our patient hydroxychloroquine. Yes, we do it. It is an offline therapy. We do it for the unclear deteriorating patients. But I'm telling you, lopinavir and such drugs, any other drugs, we don't have any evidence that it works, but we do it, just like Trump. And I'm thanking you very much. I'm ready for your questions.
Thank you so much, dear Dr. Desouky, for this elegant presentation. I have a question, please. You said in your presentation you asked for procalcitonin to exclude the secondary bacterial infection.
Yes.
This means that you don't prescribe antibiotics except if you have a positive procalcitonin value.
It is I know it is a very controversial. Some pneumologists, and I belong to this school, they are saying pneumonia is per definition infiltrations. And when I see an infiltration, I will give my patient antibiotic because it deserves it. Some modern colleagues and the antibiotic stewardship experts are telling us, no, the infiltrations, we know it is a PCR positive COVID patient. Why should I give him an antibiotic? And I know it is a viral pneumonia. Viral pneumonia will cause a consolidation, and the typical finding can tell us, no, don't give him an antibiotic. So we say, okay, we take procalcitonin, it is positive, okay, then it is a bacterial activity, and the bacterial activity means please give him antibiotic according to his stage. It is community acquired, then you begin with amoxicillin and macrolides, or it is nosocomial, then you begin with another broad spectrum antibiotic. My answer for you, yes, I do it so. According to the procalcitonin, because the CRP is not to trust, it will be anyway high. My problem is the procalcitonin will rise in 7 to 10 days. Anyway, also in just pure viral infection, it will be elevated. So I want to decide it very early.
Okay, another question, please. If you can tell me the single most important factor behind the low mortality in Germany, you will say?
Obligation. Let me tell you something. I have another opinion. I mean, every politician in the German society will come to the television and tell you a novel story about the efforts which are done with through the government and so on. But I will tell you, I'm living in a multi-culti governorate or a state here, North Rhine-Westphalia. 40% are non-German, and 20% are mixed, and 40% are German. And it is the biggest Bundesland, as the biggest part of the land, yeah, and biggest state in the federal. And the obligation ratio to the measures against Corona was measured 96%. Don't go to this area. Yes, we don't go. And the most risky groups, the old people, we have 40% of our people here in Germany are old people. They stayed home. They didn't. They are law-abiding citizens. They are at home. They are leaving the house only to get what is necessary. That is the real cause for the low mortality. The risk groups didn't dare themselves to go in a phase with the COVID-19 infection. If any land, if any country in the world would do that as a German, they will get the same percentage.
Okay, great. So you are telling us that the social distancing and the lockdown in some countries is very important.
Yes.
Okay. Last question, please. You said that we have two types, L type and H type. Yes. Which is more common?
L type.
L type.
L type, because the high mortality in COVID 3 to 5%.
Okay. And if we can choose the most important measure in the management, you said supportive. This is the most important line in the management. Yes. As you said, the specific drug therapy, we don't have till now an evidence-based medication that is really effective in treating COVID-19.
Yeah.
Great. Dr. Abdel Al-Maghrabi, please share with us the question from the audience.
Yeah, thank you so much for your excellent presentation. One of the audience, Dr. Ahmed Mansour, is asking, what are your expectations, especially next weeks when again normal life is back in Germany?
There is no normal life in Germany. The next weeks, I have the feeling that it is misinterpreted. We have measures. We are prevented from every gathering. It is just some places for shopping which are smaller than 800 meters. They are just open. The schools are still in the next 2 weeks closed. The universities are closed. Everything is of the online and internet. We just have some simpler or some lighter measures. 10% of the situation now. So we don't have a general open of the country. So and this was my expectation. They have successfully done a pretty job now with the distancing measures and with the lockdown and with the obligation from the people, and they will not lose it. And they dare not to tell that. The politicians will not tell you, okay, let's open it, and we have a catastrophe. Then they are away. So they will not do that. They will stay, and I think till the end of August, we will stay locked and with these measures.
I have heard that Germany will undergo a mass testing for IgG for COVID-19, and if the patient is IgG positive, he will be allowed to return for work. Is this true?
Yes, it is, and they have performed it. They have performed it in our hospital, and guess what? 1.5% of the people who were immune against the
very low.
Very low. 1.5. 1.5, and I think it is a matter of time. And we know from the discussion every day in the hospital, we are waiting for the vaccine. Without the vaccine, I don't expect any normalization of the life worldwide. Okay. Without a vaccine, we will not have it. We need an immunization against this virus, and the immunization. Either we say we make a very long plan for 10 years with herd immunity to build, or we say, okay, we have a vaccine, and the vaccine will be now available for everybody. And we know the vaccine needs minutes, at least 12 to 18 months with the experiments, with the approval. No, I don't think so. I think.
Do you recommend a mask for everyone, including the general population, of course, I mean?
The Asian do that, and it seems to be effective there, but they do that since years. Did you have always see the Asian, the Japanese, they come here in the airport and they are wearing their mask. It is some sort of traditions or habits by them. The CDC has changed its opinion and says, okay, it is effective. The Austrians say, okay, we do it as an obligation. Our Chancellor, Mrs. Merkel, says, okay, please do it, but it is not an obligation. So we have a lot of opinion, but anyway, I would recommend the mask because it gives you and your neighbor and your talker an impression. We must protect ourselves. So if it does protect you 10 or 20%, but it gives you always the message, please protect yourself, please distance yourself from the other person, and it is very effective. It is just a reminder for you. So if the country can afford it, I cannot come in Egypt and say, hey, please, every one of you must have a mask. Okay, I'm sorry, but a lot of people will not be able to do it. So I will save it for the people who are in real need. So I will say it is a good thing, and I will follow Mrs. Merkel and say, but it is not an obligation.
Great. Other questions, dear Dr. Abdullah, please?
Yeah, there was a question from Dr. Tansid. What about herd immunity? Are patients mounting antibodies? I think you answered that.
I answered it. We have a very low percentage, 1.5. We must wait till the test comes. I mean, in August, it will be. It makes sense to test the people, but I don't expect a herd immunity before 2 years. When I say that, or a vaccine, and I am for the vaccine.
Another question from Dr. Muhammad Radi. Could you please highlight the role of steroids again?
Yes, it is not. First of all, it is not a routine thing. It is not a routine medication to give the very normal COVID patients. It is something for the deteriorating patients, and it is against shock. It is a anti-shock measure and anti-hypoxia for the resistant cases. It is not an ordinary medication because it can lead to an adverse effect, and it can lose the immunity, and it can lead to catastrophes. So please give the corticosteroids for the patients who are in the ICU, who you can monitor every day their balance, their fluids, and their electrolytes, and for the patient who can you every day measure their deterioration or progression. That's what I can tell you about the glucocorticoid. The scheme with methylprednisolone or the other schemes are available everywhere. It is very important to decide it pretty, not to give the false patient the right medication and wait for the better results. It will not help.
In other words, we can say it is a last resort in patient with cytokine storm syndrome.
Yes, it is so. But I think if we have an ICU specialist here, he would raise his objection because they use it every day with septic patients, with hypoxic patients. Also, not only the COVID patients, but the ICU patients receive a lot of glucocorticoids.
Yes, I think we must balance the benefit versus the risk of immune suppression from the steroid in the context of fulminant infection.
Yeah,
this is very important.
This is very important.
Another question, Dr. Abdullah?
Yeah, there is another question, couple. One of them is asking about your opinion as an explanation for low infection rate in Egypt.
To the mercy of God. To the mercy of God. Let's say that trust and be optimistic. I'm very optimistic about the situation in Egypt. I was very pessimistic in the beginning because I know the measures in Egypt. It is not the measures that you can promote in 1 day or 2 days or even in years. You need hard work for decades, for environment, for development, and for a lot of financial support. And I think Egypt has a lot of problems. So let's ask ourselves, what can we do? The low numbers of infections in Egypt can be just an artifact from the system. We don't have a very good statistics, and it can be that we have another condition that we did not examine till now in Egypt that lowers the infection rates. We don't have a novel detailed study and examination for the SARS-CoV-2. So it can be another factor which we cannot measure. So I would say it is the mercy of God. I believe in it, and I think it is the only explanation for me. The other scientific explanation, I don't have any evidence about it, but I would say please check the statistics if they are right.
Okay. Any other question, Dr. Abdullah? Dr. Abdullah? Dr. Abdullah al-Maghrabi, do you hear me? So I think there is no more question. Thank you so much, dear Dr. Desouky, for this excellent presentation. And now we will move to the second speaker, my dear friend, Dr. Shady Hamoda, cardiology specialist in Ibrahim bin Hamad Hospital in the United Arab Emirates. And he will talk about CPR and aerosol generating procedure. Are you ready, my dear friend?
I am ready, Dr. Ahmed. First of all, thank you so much for hosting this great event, which we all of us need. And thanks more for inviting me to be a speaker in this event. So without further ado, I will start immediately. Okay, you can see it now?
Yes.
Okay. So Bismillah ar-Rahman ar-Rahim, we'll start now. My presentation today will be about a very important topic, especially for critically ill patients who are COVID or suspected even to be COVID-19. The aerosol generating procedures, the precautions needed, and the CPR recommendations amidst the COVID-19 outbreak. I have no financial disclosure on conflict of interest in this material. My contents today will be, first, what is aerosol and how it is generated, and how aerosol can be transmitted in COVID-19 patients, and examples to the common aerosol generating procedures in our practice in hospitals. What are the general precautions that needed based on the guidelines now, which is abundant. And at the end, we'll talk about the cardiopulmonary resuscitation for patients with COVID. This paper was released in 2014 by WHO after the SARS-CoV-1, when we started to gain more knowledge about the aerosol generation and in ICU patients. And aerosol is defined or is when air current moves over a surface of film of liquid, it will generate small particles at the air-liquid interface. The particle size is inversely related to the velocity of the air. So when the air velocity is higher, the particle size will be less. Also, it's related to the pressure of the air. The pressure goes higher, the particle size goes smaller. If this procedure causes the air to travel at high speed over respiratory mucosa or epithelium, like in the respiratory tract, the aerosol will be generated and it will contain the droplet within it. So in the WHO paper that was released in March 29 about COVID and modes of transmission, in general, respiratory infections can be transmitted through either droplets of different sizes. If the droplet size is more than 5 micrometer, we call it respiratory droplet. And if it's less than 5 micrometer, we call it droplet nuclei. The basis for respiratory infection, if it's droplet transmission, is via this respiratory droplets. But if you can generate droplet nuclei with very small size, like less than 5 micrometer, now it can be airborne. So this airborne transmission is defined as presence of microbes with droplet nuclei that can remain in air for long periods of time and can travel for longer distance. And according to the current evidence and to our knowledge now, COVID-19 is primarily carried through respiratory droplets. So it's mainly a droplet transmission. However, and this is the main essence of my lecture today, airborne is possible in COVID-19 patients if you are doing a specific aerosol generating procedure. So what are the aerosol generating procedures that are common in our daily practice in ICU? The first of all, the intratracheal intubation, bronchoscopy, open suctioning, administration of nebulizers, nebulizer in general, if it's open nebulizers, manual ventilation before intubation. When you turn to the patient to prone position and from position to supine again, turning the patient itself can cause aerosol. When you disconnect the patient from ventilator, non-invasive positive pressure ventilation, tracheostomy, and CPR, of course. So if you check this list, it's what we do in ICU. This is most of the procedures that are done in ICU for critically ill patients. They generate aerosol, and they predispose the staff or the health workers to inhale this droplet nuclei. And the issue with droplet nuclei is because if it's small size, it remains in air for longer time, it travels for longer distance, as I said, and because the size is very small, it can travel deep into the bronchial alveolar tree. So it can cause lower respiratory tract infection. And there was a question, are all those procedures can generate aerosol to the same extent? And to answer that, there was a paper that was published in 2012 in Canada. It's a systematic review that's collected data from several trials after also the first the SARS-CoV epidemic in South Korea. And they found that tracheal intubation by far is the highest aerosol generating procedure. And tracheal intubation carries a very high risk for aerosol generating procedure. And the least to generate aerosol is high flow oxygen by the usual face mask, like the nasal cannula up to the non-rebreathing face mask. But when you create a closed circuit ventilation, the risk of aerosolation goes to the minimum. So when you put a tube that is cuffed and you connect it to a ventilator and you connect the exhaled gas line to a HEPA filter that can filter the virus and put a suction tube within the line, now you created a closed line or a closed circuit ventilation. This closed circuit ventilation carries a lower risk of aerosolization than any other form of positive pressure ventilation. And this observation led us to what I will say later on, because this is a basis for all the guidelines now. The trend now is to start closed circuit ventilation as soon as possible. So the million-dollar question, should I wear N95? Should I wear surgical mask? What are the differences between them? Okay, by default, N95 masks are manufactured to filter 95% of droplets smaller than 0.3 micrometers. However, if you see here, surgical mask can filter particles or air respiratory droplets that are larger than 10 micrometers. So when you are in the phase of aerosol generating procedures and you have a very small or tiny droplet nuclei, your surgical mask is useless. It cannot protect you. In contrast, the N95 is by default and by regulatory requirement is designed to filter by efficacy that more than 95% very tiny droplet nuclei. The second difference is N95 is designed to have a good nasal and mouth seal, in contrast also to the surgical mask. So when you put your N95, you fit it to your face, you have a good seal for your respiratory tract inlets, and then you press the metal band so that you have a tight seal now. Surgical mask, you cannot do that. Based on that, if you are performing aerosol generating procedures, it's recommended to use N95 or higher level of protection like FFP3, for example. Don't perform any aerosol generating procedure if you are while wearing only surgical mask. It doesn't protect you at all. So what are the general precautions if you are doing aerosol generating procedures? Last March, the American Heart Association released an interim guidance for healthcare providers during COVID-19 for CPR and for emergency situations. And they talked elaborately in the aerosol generating procedure precautions. First of all, the patient should be allocated in airborne infection isolation room with negative pressures or HEPA filters at least. No, and the ventilation or the AC of the room is not shared the exhaustion with other corridors or other rooms, so the pathogen can be filtered. And when you are performing any of this procedure, you have to limit the number of the providers during the procedure to the people who are really needed to be there. Not everybody can go inside. And before entering this airborne infection isolation room, you must perform good hand hygiene, as Dr. Mariam showed us in yesterday's lecture. And you have to wear your PPE. And the PPE here should be N95 respirator or respirator instead of face mask. Eye protection, gloves, gowns. This was explained in details yesterday by Dr. Mary. Important consideration here, and this was based on the observation I mentioned earlier, if intubation is needed, use rapid sequence intubation with appropriate PPE. So you have to give a good muscle relaxant for the patient. You have to do it with a rapid sequence, so to avoid a lot of exposure, to avoid patient coughing and straining with you. And if possible, avoid any procedures that can cause aerosol generating, like back valve mask, nebulizers, and non-invasive positive pressure. And when you have a patient that is going into acute respiratory failure, the best course of management is to consider early endotracheal intubation and closed circuit ventilation to minimize aerosolization, as I said earlier. Of course, the room should be cleaned and disinfected after each procedure properly. At the same time, the World Federation of Societies of Anesthesiologists released a directive paper that said the same as the American Heart Association guidelines. Before you enter the room, you have to perform hand hygiene, full PPE, minimize the person inside, and it has to be in airborne infection. When you prepare, you have to choose the most experienced personnel. This is very important. You need to minimize the risk of failure to intubate. So the one who should intubate is the one who has the most experience in intubation and least likelihood to fail. If you have a video-assisted laryngoscope, this would be great to minimize the exposure and to raise the chance of success to intubate. And the rest of the items are exactly as mentioned by the American Heart Association. So COVID-19 and CPR. What I'm going to say is for both suspected or confirmed cases, you treat them the same or you take the same precautions, not only for confirmed cases. And just in this April 2020, American Heart Association released a very, very nicely written paper, and it talked elaborately on the both basic life support, advanced life support precautions in both adult and children. And I'll talk about the general precautions during CPR and then the specific procedures for in-hospital cardiac arrest for adults, because all of us are healthcare workers and most of us are adult physicians. Pediatric physician can go to this paper, which I'm presenting here, for details about pediatric CPR. First of all, what are the factors that contribute to increase the likelihood of CPR or arrest in COVID patients. About 6% of COVID patients can become critically ill, either due to hypoxemic respiratory failure secondary to the ARDS or myocardial injury, arrhythmia, shock, and in addition, some of the proposed medications, like the combination between hydroxychloroquine and azithromycin, also Calitra, which is lopinavir and ritonavir, they all can cause QT prolongation, and in a susceptible patient can cause ventricular arrhythmias. In addition, resuscitation by itself exposed the healthcare workers to many risks. First of all, the number of resource-generating procedures we do during the CPR are enormous. You do chest compression, you do post-pressure ventilation, you can do advanced airway management. This all can lead to resource generation. And it's estimated that the virus or the pathogen can remain in the air for about 1 hour or more after CPR. So everybody in the room, if not fully protected, he is liable to get infected by this droplet nuclei. And CPR require a lot of patients, a lot of people to be inside the room. So, and they are close to each other. So the likelihood of infection gets higher. And of course, because it is a high stress situation. So as doctors and as physicians, we will not, by our nature, will not be facing a patient who is arresting and we will leave him. And this can be at the expense of our own protection. So this high stress emergency events may lead to lapses in infection control practices. So let us go to the general principles for resuscitation. First, we have 3 important pillars during CPR. First of all, and this is the most important, you have to reduce the provider exposure. You have to reduce the exposure of the healthcare workers. Don't go inside the room without donning full PPE. This is very important, and it's a common sentence or a common message in all the guidelines now talking about CPR. Don't go inside without donning full PPE. This is number 1. Number 2, as I mentioned before, only the people who are really needed to be there should enter. A lot of people can be there and they don't do anything. This should be guarded by someone at the door to prevent people who are not needed to be inside. If you have a mechanical CPR machine, you can use it if it's available and the patient fit to it. And second thing, this cardiopulmonary arrest in COVID patients are mostly a respiratory arrest. So the priority for your CPR protocol is oxygenation. And the second priority is to lower aerosolization. So you have to use HEPA filter regardless of the ventilation method you are giving. If you are giving back valve mask, attach to it a HEPA filter. If you are using a mechanical ventilator, attach a HEPA filter to the exhaled gas line, and intubate early. Perform a closed circuit ventilation, as I mentioned. Also, this is to minimize the risk of failure. You have to engage the intubator with the highest chance of first pass success. The one who should try to intubate should be the most experienced one. And when you are trying to, from chest compression, pause it for air management. We know from the previous ACLS guidelines that intubation was not mandatory. You can do the ambovag ventilation. This is before the COVID era. If you don't need to pause the CPR to intubate, if you can deliver good oxygen with non-invasive ways. But in COVID era, you have to put tube to minimize aerosolization. Also, if you have a video laryngoscopy, it would be better to minimize the risk of failure and to decrease the exposure. Before intubation, you have to use a bag mask device with a HEPA filter, again with a HEPA filter and very tight seal, very good seal. For adults, consider passive oxygenation. As I mentioned before, oxygen supplements like face mask has a low risk of aerosolization. So if the patient can be maintained on a non-rebreathing mask during the CPR, keep it. And if intubation is delayed, consider supraglottic airway and minimize closed circuit discontinuation. This is very important. You have to secure any line you will put. You have to secure the tubes, the ventilator connections to avoid any circuit disconnection. And consider resuscitation appropriateness. Does the patient really need to be resuscitated or no? Some people are terminally ill and they have irreversible shock. Those patients are eligible for do not resuscitation. So you have to consider DNR now in this situation, and many countries now are implementing the DNR policies. So what are the in-hospital cardiac arrest precautions now? Specific guidelines based on this American Heart Association paper. Before arrest, the main goal to be proactive. And this is very important message. Don't wait for the disaster to happen, then you have to face it. In COVID era, you have to be proactive. You have to anticipate the patient condition. You have to foresee it so that you will not be faced with unexpected arrest or unplanned emergent intubation. And this would maximize your exposure. This will be hazards for everybody. So be proactive. How I would do that? First of all, you should assess the appropriate level of care for the patient. Does he need to be in a ward, regular ward? Should he be in ICU? This should be assessed from the beginning very properly. If you feel that the patient is ill or has many comorbidities, his saturation is not good, you have to be proactive. Don't wait till he crashes. Transfer to appropriate level of care. And again, assess for DNR eligibility. Closely observe your patients. Clinical signs of deterioration, very important, signs and symptoms. And if you feel the patient is a high-risk patient for cardiac arrest, move him to an airborne infection control room, a negative pressure room, so that when the arrest happens, you don't have to move him from an ordinary room or an isolation room to an airborne infective room. And people, and I know that from my experience, we used to forget to close the door. This is very important, because if you are not in AIRS room and you close the door, the whole corridor, the other rooms will be contaminated. Everybody around you will be contaminated. So close the door after you enter. So how about if a patient is already intubated and he arrested, and how to manage the mechanical ventilator? From our practice before, when a patient arrests and he is already on a tube, we disconnect the tube, we put ambo bag, and we do manual ventilation by ambo bag. This was before the COVID era. Now this is not the way to practice CPR now. If your patient is on a tube and he arrested, leave him on the mechanical ventilator and the tube to maintain the closed circuit, to reduce aerosolization, and adjust the ventilator to be appropriate for the CPR. And how this can be done? First of all, increase your FiO2 to 100% or 1. Adjust the ventilator to allow for asynchronous ventilation so that it will give his adjusted parameters regardless of the patient. Change the mode to pressure control ventilation, assist control. This means that I will adjust my pressure so that the patient can receive a tidal volume of about around 6 milli per kg of ideal body weight. And adjust the trigger to be off, so that when you are doing chest compression and you are doing your CPR, the ventilator will not be triggered by chest compression. So you need to trigger to off the trigger of the ventilator, because if you keep it trigger on, the ventilator will be triggered with each chest compression. This will lead to air trapping, hyperventilation, increase inspiratory pressures inside the lung, and more liability for barotrauma. Put the respiratory rate to 10 minutes for adults. Assess the need to adjust, assess the PEEP level you need to balance the PEEP between what's appropriate for to maintain good lung volumes and good recruitment for the lung alveoli without impairing the venous return and more deterioration for the blood pressure. So you have to put in the PEEP that can give you adequate lung volumes without impairment of the venous return and blood pressure. Off alarm, because alarm will get fatigued after some time. Ensure that everything, all the lines, all the tubes are secured. You don't need a closed circuit discontinuation during CPR. And when ROSC is achieved, you can put the ventilator back to the usual parameters as it was before or per the patient condition. But this is the appropriate ventilator settings during the CPR. Again, don't disconnect the tube and put on ambu bag like we used to do before in our usual practice before. Keep the ventilator on, keep the tube on, maintain the closed circuit ventilation, and adjust your ventilator accordingly so that it will be interrupted. It will not be interrupted by your CPR and chest compressions. How about patients who are in prone position during cardiac arrest? A lot of papers now and a lot of physicians are practicing conscious proning. So the patient, while he is conscious, he can prone himself for some time, and we assess oxygenation. If the patient can have improved oxygenation during conscious proning, we keep him for like 16 hours or whatever. And sometimes we put a tube to a patient and prone him to improve oxygenation. So if the patient is prone already and then he arrested, you have either one of two situations. And this is for ICU people. If the patient is in prone position and he has no advanced airway, you have to turn to supine position. If he has no advanced airway in position and he is prone, you have to turn him to supine position for advanced airway management. But if he is prone with advanced airway already or intratracheal tube, you can perform your CPR in prone position, unless you can turn him to supine without disruption of the circuit. If you are sure that you can turn him to supine position without disruption of the circuit, better change to supine position. If it's not guaranteed, keep him in prone position. Attach your defibrillator to the anteroposterior position and perform CPR at thoracic vertebrae number 7 to 10. This area, you should attach your pads like that, and this is the anatomical position for the chest compression. Keep in mind that effectiveness of CPR in prone position is not completely known. We don't know how effective it is, but for the sake of minimized aerosolization, we can consider it now, especially if turning the position to supine can increase the risk of circuit disconnection. A changing position between prone and supine is AGP. I mentioned this before and I'm emphasizing it again. It's not an easy or a safe thing totally to change from prone to supine and in the opposite. What about if a patient that is pregnant and arrested? The guidelines for the CPR during this situation are the same. It's not changing, but you have to notify the obstetrician's team. Within 4 minutes, the obstetrician team, the anesthesiologist, should be assembled for possibility of urgent perimortem delivery. Within 4 minutes, everything has to be ready, because if the CPR will not be successful, you can consider perimortem delivery. So this is the algorithm for the cardiac arrest, but as per the American Heart Association. And the first step and the first message here is to protect yourself. Don't PPE. Don't go inside without PPE protection. Limit the personnel. Again, limit the personnel and consider the resuscitation appropriateness, as I mentioned before. When you start CPR, your main priority here is oxygenation and ventilation. If you can keep on oxygen to limit aerosolization, keep it. Attach the monitor and prepare to intube it. Checking the rhythm here is very, very important, because if the patient in a pulseless VTAC or a VF and you can deliver a shock, you will not need to do the usual CPR. So if when you are assessing the patient, first check the rhythm. If it's shockable, shock, okay, without starting the chest compression. If it's unfortunately not shockable, so you have to continue to the other steps of the algorithm. Your priority again for intubation. You have to pause chest compression, as I mentioned, to do intubation. If intubation is delayed, consider other advanced airway management like supraglottic airway management. Connect to ventilator with possible with HEPA filter if possible. The rest of the CPR algorithm is not different from our CPR or ACLS protocol before. It's the same. Just what is really important here to remember and keep your mind is that your safety is the priority. Don't go inside without full donning of PPE, level 3 PPE, level 3 personal protective equipment. Your priority is for ventilation and for oxygenation. Don't disconnect the tube, keep the ventilator, adjust it to the parameters that can ensure successful ventilation during the CPR. Another paper by the Resuscitation Council in UK was issued. This was before the American Heart Association, and it's not big difference, just subtle changes. Subtle difference I will show to you. Again, they emphasized the need for early detection of patient at risk to avoid unnecessary or unprotected cardiac arrest or unprotected unplanned intubation. When you check the pulse, they emphasize that don't check for breathing. When you check for recognition of the cardiac arrest, we usually check for breathing and for pulse. In the British guidelines, don't check for breathing. Check only for pulse. If the pulse is not present and the patient is unconscious, you have to start CPR. And they mentioned and they emphasized on don't start chest compression yet. You have to go outside again. You have to announce that there is a CPR or a code blue in the certain location. Then you go outside. You don't your PPE. Meanwhile, you can attach the patient to the monitor. You check the rhythm. If it's shockable, you can deliver the shock. Delivering shock doesn't cause aerosol generation. This is very important. So if you are inside the room and you are not on PPE level 2, level 3, you can still assess the patient. You can still give him shock. You can still attach him to the monitor without being more exposed to aerosolization. However, if you are going to do CPR, you have to go outside and change your PPE to a level 3 PPE. And I will show you the difference between PPE level 2 and PPE level 3 now. It's not recommended to use bag valve mask. It's not recommended to do CPAP, to perform CPAP ventilation, non-invasive, or non-invasive post-pressure ventilation. This is all not recommended. If the patient is already receiving supplemental oxygen, this was mentioned before, using a face mask, you can keep it to limit the aerosolization. This is the same. And this is a very nice algorithm by this mentioned in this paper. What are the things I can do with level PPE 2 and what I can do unless I am in PPE level 3? And this is the difference between PPE level 2 and PPE level 3. The main difference is the N95 mask. The other PPE are almost the same. But if you are not wearing an N95, you have to change it into N95. So what I can do safely while I'm still in PPE level 2, I can assess responsiveness, I can assess rhythm, I can give shock without need to be on PPE level 3 protection. I cannot start CPR without donning level 3. So again, don't do chest compressions, don't do intubation without being in full PPE level 3 precaution. It's very important to dispose everything as per your local guidelines or manufacturer guidelines. Any work surface has to be cleaned properly with proper disinfectant. Ensure equipment safety and equipment proper cleanliness after the CPR is finished. If you used as Yanker suction, don't leave it on the patient pillow. Okay, you have to put it inside a disposable glove and tie it properly. Remove your PPE safely. This was mentioned like but yesterday by Dr. Mariam. And this is another. This is a nice infograph mentioned in the same paper. This is what I mentioned already. There's nothing new in it. Thank you and stay safe.
Thank you so much, dear Dr. Shady. Excellent presentation. I have a question, please. Can you repeat again the difference between level 2 and level 3 protection?
Both are gowns, surgical gowns or aprons, face protection by goggles or face shield, and gloves, single pair of sterile gloves. The main difference is in the respirator protection. Level PPE, level 2 PPE, you can be on surgical mask. To be on surgical and to move into level 3, you have to put N95 respirator or FFP3 respirator. This is the main difference. You can be on apron in level 2, but you have to, if you are wearing an apron, you have to change it to surgical gown.
Okay, this is very important as you know, as a type of arrest, we have no time to waste. So
Yes.
I think all the medical personnel should be ready in at least level 2 protection.
Yes.
And if there is arrest, they can rapidly switch for the level 3. It will take less than 1 minute, I think.
Exactly, and I want to emphasize again about the point of being proactive. You have to be extra cautious. You don't want to be exposed to anticipate, to foresee. If you have patient that you feel that he might go into cardiac arrest or a clinical deterioration, or he might need intubation in the future, don't wait and don't waste time. Before, and all of you know that we used to have a high threshold for intubation. We wanted to give a patient a chance to recover by himself, because we are afraid if we intubate, we might not be able to extubate. And so that we want to give a more chance for recovery by the patient, try medical treatment. We don't have medical treatment proved for COVID. We don't know what can happen anytime. Situation can change very rapidly in COVID-19 patients. And I have seen this many times.
Yes.
So if you have any feeling that the patient might deteriorate, better keep him in airborne precaution room, better keep him in very close observation, and better if he's showing signs of respiratory failure, put a tube and with closed circuit ventilation. Everything that in emergency we do in emergency, it has to be done in COVID with precautions. And as I said, as we are physicians, and we will not see somebody dying in front of us and we will leave him. And this can come at the expense of our own safety. So better to be ready. This is the main.
This is reflex.
Yes, this is reflex. You will not see somebody dying and you will just stand watching him. You will do something. And it's either you are sacrificing yourself or sacrificing the patient if you are not ready in advance before.
Yes, I will focus also on your very important point about the arrest in already ventilated patients, and not to disconnect them from the mechanical ventilation.
Yes.
This is new recommendation to decrease the risk of infection for the healthcare provider.
Yes.
And also the prone position, this is new as well.
Yes. Exactly.
I think we have many questions, dear Dr. Abdullah, from the audience.
Yeah. Thank you so much, Dr. Shady, for this great presentation.
Thank you, Dr. Abdullah.
My first question is from Dr. Irina. Do you recommend wearing N95 in every patient for every procedure performed, considering the risk of examining asymptomatic patients, for example, when performing echo in patient who is not COVID suspect?
No. Surgical mask is enough if you are not doing surgical aerosol generating procedures. So if you are examining the patient, if you are doing echo, if you are not doing anything that is not aerosol generating, you can safely be on surgical mask. COVID-19 transmission is droplet, okay? So, and the size particle or the respiratory droplet particle is by default is more than 10 or 5 micrometer, which is can be efficiently blocked by the surgical mask. The situation that you need to change to N95 or a higher level of protection is when you are doing aerosol generating procedures. And we need to keep in mind very important thing here, because we don't know when the situation will be relieved. And in the future, we will be faced with a critical situation of resources. So resources cannot be forever. So we need to limit our usage for what we really needed. You don't need to put a face or N95 for every patient you see, and when you have an arrested patient, you don't find the N95 anymore. So this is misuse. You have to use the N95 only when it's needed, so that when it's needed you find it. This is very important. The supply cannot remain forever.
Another question is from Dr. Fadi Gerges. What is your input regarding what is mentioned in some literature that STEMI patients with suspected or already diagnosed COVID is preferred to be intubated from ER before?
Can you repeat it again, dear Dr. Abdel?
Can you repeat? Yes, please.
Yeah, in some literature in STEMI patients with suspected or already diagnosed COVID-19, it is preferred to intubate the patient from ER before shifting to cath lab, even if not yet eligible for intubation. So what is your input regarding this, and whether we intubate all STEMI suspected COVID-19 patients from ER to limit aerosol dissemination in cath lab, or shall we follow casual intubation criteria?
I agree on full intubation. First of all, most of the cath lab are not prepared to be airborne rooms.
Yeah.
Most of the cath labs, they don't have HEPA filters, or they don't have negative pressure. So we know that any patient with a STEMI during primary PCI can arrest, or at least can go to interpulmonary edema or ventricular fetal or malignant arrhythmia that need intubation or need DC shock, right?
Yeah.
If you perform any of this without full protection PPE level 3 and not in airborne prepared room, you are exposing the whole hospital. Okay,
yeah.
This is very important. You are exposing the whole hospital, not only the cath lab. If the air condition is dissemination or exhaust is shared between the corridors of the hospital, and you are not in airborne prepared room, it's not only your cath lab that's infected. It's the whole air supply. So I prefer, if you are going to do a primary PCI for the patient, either do it with full PPE 3 in airborne room, if your cath lab is prepared to be airborne, precaution, or put intubation, which is the safest course for the management, is to put intubation and to maintain carotid circuit ventilation.
Another question from Dr. Muhammad Ibrahim Abdurrahman. How do you declare the patient for DNR? Do you take consent from the patient or his relatives before?
This differs from country to country.
Yeah.
Each country has its own recommendation for that. In UAE, we didn't have before, we didn't have DNR, but we are starting to implement now. And we don't need to take the patient, the relatives' consent. We just inform them. But their consent or their approval is not mandatory, not required. You have to perform them. To get DNR, you need the opinion of 3 consultants. One of them is a neurologist, or at least the attending physician if he is on mechanical ventilator.
Yeah.
I mean, if he arrested before and his conscious level is deteriorated, better to include one neurologist with you to do EEG and to confirm at least if there is brain death or something. But if he didn't arrest before and he is critically or terminally ill, many patients have cancers or have terminal disease or go into refractory or reversible shock. You can get the opinion of the documentation of 3 consultants and document it and inform the family. Again, it differs from country to country.
Yeah.
But this is the main frame of it.
The last question is from Dr. Eager to know, do you think forceful coughing from COVID-19 patient is not aerosol producing action?
As I said before, aerosol generation is when air current moves at a high speed over a mucus or a liquid film on the mucus, general is generating. And it depends on the velocity and the pressure of this air current. So when it's a higher speed, when the velocity is high, you can generate aerosol. So forceful cough, I think, and I believe that it can induce aerosol. And I think this is one of the explanations. It's not declared officially yet, but this one of the explanations why this very high infectivity of the disease. It's spread everywhere, even if people are staying at home, and so aerosolization is possible. We have no document till now that cough can induce aerosolization, but theoretically, yeah, it can, especially forceful coughing, yes, because the air current will be of high velocity and high pressure.
Thank you so much.
Can be applied for transesophageal echo as well.
Transesophageal echo is, it's not mentioned, but it's like bronchoscopy or like endoscopy. Yeah. This is an invasive procedure, can induce cough, and I believe I think there is a recommendation in the European Society of Cardiology paper released for echo preparation that if you are doing transesophageal echo, you have to be on aerosol generating procedure precaution. And if it's not mandatory, don't do it. Okay? Yes. It's not.
I'd like to ask you about if the initial rhythm was shockable.
Yes.
You have said that you can give DC shock, and if it was successful, we can stop the resuscitation, and there is no need to do a chest compression. In the routine, we do a chest compression for 2 minutes after the DC shock.
In the routine, you have to give DC shock, then do one cycle of chest compression, then reassess the rhythm. Okay. Yes. This is not the situation here now. If you have this is based on the British Council recommendation. You assess the rhythm. You have a shockable rhythm. Give DC shock and assess the rhythm.
If you return it back.
No need for chest compression. No need for chest compression. Yes. Great. And this is very important. This is very important. It makes sense, actually. It makes a lot of sense.
Yes. Totally agree.
Yes.
Any other question, dear Dr. Abdullah?
Oh, there is no more questions. They are repeated also.
Okay. Thank you so much, dear Dr. Shady, for your elegant presentation.
Thank you, my friend. I'm very happy to be here today. Thank you, Dr. Abdullah. Thank you, Dr. Mohammed. Thank you for all the audience. I hope you liked it. Stay safe.
Thank you so much.
Thank you.
And now we will move to our great speaker, Dr. Ahmed Farid, cardiology consultant in Suez Canal University. And he will talk about precautions during cardiac imaging.
Good evening, everybody. It's nice to see you all. You're all my friends and dear colleagues. And I would like to express my gratitude for inviting me to such a great webinar from all over the world. Thank you, Dr. Ahmed, and thank you, Abdullah, and thank you everybody who shared in this magnificent event. And special thanks for the previous two speakers, Dr. Shady and Dr. Desouky, for giving this such a great lectures. My lecture is going to be not so long one. It's going to be about a topic that we face every day. It's about the precautions you should take for cardiovascular imaging during a COVID-19 pandemic. Is the presentation is now clear and you can see it?
Yes, it is clear.
Okay. First of all, I would like to say to everybody who is attending us, stay safe, my dear physicians. You are the heroes of the current time. So stay strong, stay safe, and take care of yourself and your families. So I will start first by saying that the COVID-19 pandemic increased the burden of cardiovascular imaging services in general. And however, given its wide availability and key role as a bedside test, echocardiography, especially the echocardiography, is the most affected cardiac imaging modality. My lecture is based on the article that has been published in the European Society by the European Society of Cardiology about the recommendation on the precautions, indications, and prioritization and protection for patients with healthcare personnel in COVID-19. That has been published in March 2020. You have two main challenges for cardiovascular imaging during this time. You have limited expert staff, as some of them are sick, some of them are risky, and some of them are redeployed in a prioritized area, like they went to the ICU or to special places. Also, you have a risk of peri-procedural transmission. So these challenges are very important, and you have to take care about this. Generally, as mentioned before, the mode of transmission of the COVID-19 is mainly by the droplet infection, either by the breath or by through coughing or by through the contact of a surface that has been infected by the droplets from an infected patient. So the echocardiographers are in particular, and the cardiac images in general, are in close contact with the patient and therefore likely to have high risk of being infected. When you do echocardiography, you are very close to your patient. And sometimes if you are wrongly positioned, you may be in the front of the face of the patient and taking all the droplets in your face. So you have to be aware of this, and this puts you in a very high risk for being infected. Also, the transesophageal is considered. It's by itself, it's not an aerosol generating procedure, but the procedure itself may lead to aerosol producing environment, like when you have suction, when you change the position of the patient, if the patient cough, if you go with the probe in a wrong position and go through the trachea in a wrong way. So the risk of the aerosol generating in the transesophageal is very, very high. So it's very dangerous. And the risk of contamination of equipment and personnel is very high during the transesophageal echocardiography. So the transesophageal echocardiography is on the top of the dangerous cardiovascular imaging procedure that we will talk about. So you need to repeat your transthoracic. You may send the patient for a CT scan or an MRI as an alternative to keep away from the transesophageal as possible. And this graph shows how many or how the risk of development of the infection or transmitting the infection during the procedure. The CT, the MRI, and the SPECT are the lowest. The transthoracic echocardiography has higher intention, and on the top of this is the transesophageal echocardiography. But CT and CMR have also may also have a significant potential for contamination of personnel, patients, and especially linked to transportation, but also via direct contamination during the scan. So if you transfer a patient that have suspected or have confirmed COVID, when you transfer this patient from the ICU to the scanner, you have a risk to transmit this infection through the way of the transmission, which is very important, and you should take all the care during the transmission of the patient. Also, the scanner and the scan and the personnel working in the scan itself may get infected from the patient. The risk of infection for the professionals, because the technicians, the physician and nurse and other personnel may get infected when a patient coming to the scanner, either the CT or MRI or the SPECT. The risk of contamination of the equipment and facilities. Also, there's risk of widespread contamination due to transportation of a critically ill patient or infected patients. The prolonged duration of the cardiac imaging study will increase the likelihood of contamination, especially if you are doing an MRI. So the patient stay inside the scan for a longer period of time, which make more time for the transmission of the droplets and the infection. There's another important thing that many patients with COVID-19 pneumonia have elevated troponins and signs of coronary artery disease. So you may have a patient that came and suspected to have a COVID-19 pneumonia, but he have a chest pain, and during the workup, you may find that his troponin is elevated. So you are now stuck. Does this patient had an on top unstable angina or an STEMI or an STEMI on this patient or not? And the best way to deal with this patient, send him for CT. And sometimes you will need a CT in a very confirmed patient due to the elevated troponin in these patients. So the main lines for your work as a cardiovascular imagist in this area is two main things: prioritization and safeguarding. So if a patient came to you to perform one of the non-invasive procedures, you have to ask a main question. Will undertaking this study will substantially change the patient management or be life-saving or not? If yes, proceed. If no, reconsider or reschedule or even cancel the procedure itself. So this is what's called filtering of your patient. And there's some hospital that has the system for performing this. If your hospital is allowing you for deferring patients or canceling patients, it's fine and good. If no, you have to be selective in what you are doing and selective for this patient, and you try to filter your patients or patients you're working on. We have to say that elective, non-urgent, and routine follow-up exams may be postponed or even canceled. And this has been published by the American Society of Echocardiography in March 2020. It's about if you had a patient came for an echocardiography, you ask the patient, is the echo indicated as this time? If no, defer and reschedule this study. If it's not decision management or affect the management of the patient or affect the life of the patient, you may defer or reschedule the study. If yes, you have to assess the condition of the patient. Is he COVID suspected or COVID positive? If negative, you do the standard precautions and perform a limited study for him. If he is positive, you can go on with the schedules that is written here with the protocol. Either use the focus or focused imaging, and you use special staff, as we will mention later, for their protection. So who should be rescheduled? All elective exams that is not decision-making should be postponed or rescheduled, like the preoperative studies with canceled surgery procedure. Patient has been planned to do a surgery and he is asked to do an echocardiography preoperatively, and the surgery has been canceled for something. So you have to omit this study. The annual exams, yes, we all know in theory that should not be exist, but there's some patients that perform an annual exam for prosthetic valves, for following up of regurgitation, for following up of a lot of stuff. This may be rescheduled. Reschedule all exams that don't change the treatment plan of the patients. Another important point here, that CT may replace transesophageal echocardiography to rule out the left atrial appendage thrombi if you're planning to cardiovert this patient. And this is a very strong and very powerful indication. And we know that the use of transesophageal in the emergency, it's not a lot. One of the major uses of transesophageal emergency is that rule out left atrial appendage thrombus prior to cardioversion. You may take the patient to perform a CT to see if there's left atrial appendage thrombus or not in the left atrial appendage, and this avoid the transesophageal as a whole. So how could we implement this in our daily practice? A big important point to know that echocardiography should not routinely be performed in patients with COVID-19 with all COVID-19 disease. Not all patients diagnosed with COVID-19 should have an echocardiography. This should be tailored according to the symptoms and according to the need and according to the decision-making in the management of the patient. Not a rule that every COVID-19 patient should have an echocardiography. Number two, the range of different cardiovascular manifestation can be found in COVID-19 patients, which may require cardiac imaging, including bedside echocardiography study. So you should take all your precautions when you are dealing with such patients. A focused cardiac ultrasound study, it's called the FOCUS, is recommended to reduce the duration of exposure. You don't need to perform the full study like the 30 or 40 minutes that we used before. You can use a very short time. You look for some points specifically, and then you may take your measurements offline after acquiring the images. And here is a suggestion for the using of the transthoracic echocardiography protocol in a patient who suspected or confirmed COVID. You look for the left ventricle, you look for the ejection fraction, regional motion abnormalities dimensions. For the right ventricle, you look for the size, the function, either by the TAPSE or the fraction area change, TR gradient. The valves, you look for any gross signs of valvular disease or severe lesions. If you found the severe lesion, you may go in depth and prolong the study a little bit. The pericardium, look for thickening or effusion. You even will not attach the ECG monitoring during the images. This can be omitted. And the measurements should be performed offline to reduce the exposure and the contamination. So you just go with these steps, take your images, and then take the patient out and take your measurements offline after the patient is discharged. Also, for the workers or the echocardiographer or the imagers, you may need to limit the exposure of at-risk staff members. If you have members that work in the cardiovascular imaging who has one of these criteria, they are over 60 in age, they are pregnant, they are chronically ill with multiple chronic diseases, diabetes, hypertension, coronary artery disease, or the immunodeficient patients, you may to take them out or limit the exposure to the patients at home. So you are stuck now with a complex of 3 circles: the cleaning, the protection, and the disinfection. For your equipment, all equipment used in close contact with the patient has the potential to carry droplets containing the virus. Your patient is coughing everywhere. Either he is suspected or he's a confirmed COVID, or even in the negative patients that have proved, we have seen patients that were negative, and after some time, when repeating the test again, they were positive. So you have to deal with everyone like they are suspected COVID, especially if they have any respiratory systems. So these droplets can be spread everywhere, on your machine, on your keyboard, on your probe, on your clothes, on your bed, on everything. Okay, so you have to take care about this. Also, this includes the ECG leads that may, and which should therefore be avoided when performing echocardiography studies in COVID-19 patients. So you don't need to attach your ECG for this. And we all know that we don't need that ECG that much, except if you are doing a 3D study or something like this. And we should not do this except it is highly, highly, highly indicated. So how to disinfect your equipment? You may use a moderately warm water and mild detergent constitute the basis of equipment cleaning and all cardiac imaging machine, including the echocardiography probes. And a non-alcoholic disinfectant should be used for the echocardiography probe, but you may check your vendor about how to disinfect your probes. To facilitate the cleaning of the scanner, all additional 3D and single Doppler probes should be disconnected from the scan. So most of the time you will not work on 3D this time. So you have to disconnect your probe and keep it in a closed and safe place. This makes cleaning the machine much easier and not exposing them to droplet infection. In high volume centers, one can consider dedicating a separate scanner to be used exclusively for COVID-19 patients that remains well designated COVID-19 areas. So this is very sensible recommendation, actually. If you have a high flow rate and you have a lot of patients with suspected or confirmed COVID, you may select a room or 2 with a dedicated machine or 2 machines with a selected staff. They are healthy and well protecting themselves to work on this, and leave the other machines for the healthy or the negative patients. The positioning also of the patient versus the echocardiographer and the scanner may be of importance. So sometimes you are working with your left hand, so the face of your patient is facing you and facing the machine and the keyboard of the machine itself. So this is very dangerous. So you may shift to keep your patients on your right side, or you may turn the patient, if you work with your right side and facing the patient, you may need to put the machine at the legs of the patient and you work by your right hand. And when examining a patient with a confirmed or suspected COVID, protective clothing, gloves, head covers, specific masks, and the eye shield must be used. We will mention this in detail according to the paper that has been published with the ECC. So look at this. If you have a patient with a lower risk for COVID, you may wear a surgical mask. You may wear a surgical mask. You may not wear protection for eye protection. You don't need to wear a head cap, and you may take a full study. But if you have a patient with a moderate risk or a severe risk or confirmed COVID-19, you have to properly hand wash yourself, to wear a surgical mask, and for the confirmed, you have to wear an N95 or FFP3. You have eye protection, you have the head cap, you have a short study, and the equipment protection should be protected, okay? And for the patients, if the patient are low risk, it's preferable to wear a mask, and in moderate or severe risk or confirmed COVID, they should wear a surgical mask. So you and the patient should wear a surgical mask during the echocardiography, especially if the patient is at moderate risk or severe risk or confirmed COVID-19 patients. This is for the transfer of gel. Actually, I don't recommend to do transfer of gel at all at this time. Please try to stay away from it as possible, because it requires a lot of precautions to do it properly so as not to infect you and infect the team and contaminate your machine. So try to avoid it as possible. But if you are obliged to do it, you have to do it in the FFP3 with N95 because it's an aerosol generating procedure. For the other imaging modalities, like the CT and the MRI, the imagers and the technologists should wear protective clothing, gloves, and face masks while undergoing scanning, and the patient should wear a surgical mask during the imaging. So patients also should wear a surgical mask during the imaging. The scanner, the coils, the ECG cables are mandatory for cardiac MR and CT scan, but needed to be thoroughly disinfected after imaging. So between every patient, you should disinfect your machine. This including the couch, the patient couch, the coil, the ECG cables, and the whole machine should be thoroughly disinfected between patients. Cleaning of the scanner after imaging patient with COVID-19 is obligatory, but as we said with the echocardiography, it's important surgery to reduce the contamination, to reserve one scanner for known infected patient and another for low risk and non-infected patient, if this is possible at your facility. So my conclusion after this, the COVID-19 pandemic has forced us to reconsider how best to perform cardiac imaging in the right patients at the right time, and learning how to minimize the risk of cross-infection for imagers and patients is the most important consideration in this pandemic. And thank you all, and stay safe, and waiting for your questions.
Thank you so much, my dear friend, Dr. Ahmed, for this very nice presentation. I have a question, please, about the use of CT for exclusion of the left atrial appendage thrombus. What about the diagnostic accuracy or false negative result or the negative predictive value of the CT in detection of the left atrial appendage thrombus as compared to the standard transesophageal echo?
Actually, the CT is very sensitive for detecting the left atrial appendage thrombi, especially if you followed a special procedure that's for the imaging of the left atrial appendage accurately. You can very accurately see the thrombus or exclude thrombus in the left atrial appendage. So it's not less in accuracy than the transesophageal, but it comes at the cost of giving contrast and giving radiation.
Great. Dr. Abdel al-Maghrabi, we want to hear the questions from the audience, please.
No, actually, all the audience are saying that the lecture is amazing and there is no questions till now.
Okay, this means that it was very clear lecture.
Yeah.
Thank you very much.
Thank you so much, dear Dr. Ahmed, for this elegant presentation. And at the end of the day, I'd like to thank my dear friends, Dr. Abdel al-Maghrabi and Dr. Muhammad Hamdi for moderating the session with me. And for the speakers, Dr. Desouky and Dr. Shady and Dr. Ahmed for their great presentation. We will continue the third day tomorrow of our online webinar about COVID-19 with two very important lectures by Dr. Alexander and Dr. Hatem Sulaiman, and we will wait for you. Thank you so much.
Thank you.